I'd like to invite Mike Steinmetz from Cleveland Clinic up to talk to us about combined ortho and neuro. The future is here now.
I'm going to switch gears a little bit and talk more on the operations side, looking at the future may be a combined multidisciplinary sort of standalone spine department. So we look at our traditional models of spine care, which probably many people in the room are in. There's really no unified strategy of care for the continuum of these patients with spine disease, right? Often the strategy is focused within the department or in the section. They have their own strategy for hiring, for growth, for programmatic development, research, and education. And you're often competing with each other internally, right? When we should be competing with people down the street, you may be competing with your orthopedic colleagues or neurosurgery colleagues for cases. Pain management and PM&R may compete with each other for injections, et cetera. So care is often fragmented, right? You have one nail, which is spine disease, and you have multiple hammers. And what's dictating care in many of these situations is really just who that patient sees, right? So they may see a pain management doc and get a spinal cord stim. They may see me and get a lumbar laminectomy. So the outcomes are often heterogeneous, and the quality may be the same. And as I mentioned, there's really not a competitive advantage in that situation. You're not competing as an entire enterprise on this spine service line, and it's truly physician-centered care, right? So the patient has to navigate this abyss of care, try to figure out how they get this place to place, and try to get to the right provider, and sometimes they don't in time and have multiple things done to them by the time they see somebody. So what do we do at the Cleveland Clinic? So we took a different approach, and this started about 2003 with some people that really had, I think, some advanced vision at the time of creating an institute, and that was just the name of it, but it's essentially it was a department that was focused all around the spine, and it was multidisciplinary. And you can, I think we know many of the players on this slide: Ed Benzel, Ian Kalfas, Izzy Lieberman, Gordon Bell, but the guy on the bottom right, that's Dan Masnick. He's a medical spine doctor. He's a rheumatologist that only seen spine patients. He was in internal medicine. And all of these folks came together to build this institute. And the goal was really to reduce variability, to improve quality and efficiency, and to have that competitive advantage, right? You could brand this as the Cleveland Clinic Spine Institute and advertise that brand. But more importantly, there was one mission, one vision, and one voice speaking for all of these different spine providers. And in fact, they created a mission, vision, value statement, as you would for any department. And the goal there was not just on clinical practice, but it was also everything else that goes with it: research, education, quality. Everybody was working together, rowing in the same direction on all of these avenues. And this is truly patient-centered care, right? So you have the patient in the center, and you bring everybody else around them that needs to take care of that patient. So with this, in one group working together, you can create true and effective patient care pathways, right? So the patient, it doesn't matter who they see, it matters what they're dealing with, what time frame, what cadence they're on for what treatments that they get. You can have effective triage process, right? What we strive to do is have the right patient see the right provider the very first time. That's our goal. And we can keep surgeons operating and interventionalists doing interventions, right? As a surgeon, I have no value, or the patient has no value, seeing me for chronic low back pain. I should be operating and only see patients that need surgery, and that is in fact what we do. We have other providers that can do the other aspects of that. And we could have more predictable and more homogeneous outcomes and hopefully improve our quality. So our current model has changed some over time, but it's still essentially a standalone department. If you think about it from the terms of Michael Porter, we're more like an integrated practice unit, which is essentially what we are, right? This is a functional and a structural unit that's organized completely around a patient's condition, which is spine disease in our example. And we have all services that those patients will need within that department. We have one leadership, one budget, and all of those providers work in that department. Okay, so this is not a collaborative arrangement where we're just working together very nicely with each other. This is one standalone functional IPU. And why do that? Why would you go through all the effort to put something like this together? Well, you can really have significant benefits in multiple ways. One is strategic growth. So we don't grow by just hiring more surgeons or more interventionalists. We think about, what do we need? What do we need programmatically? Do we need another surgeon? Do we need another location? And we can hire both pedigrees and fill up our program that way. On our regional practices and the main campus, we can hire interventionalists. We have a number of PM&R interventionalists and also just routine pain management physicians that don't do interventions. And as of this morning at 7 a.m., all of pain management is now within our spine department as well. And we can also bring in other providers that these patients need, like chronic pain rehab. We have pain psychologists, addiction psychiatrists, And we have MDs that are pain management trained that focus just on the management of chronic spine pain. As I mentioned, we can grow strategically. We can think about as an entire group, where should we be and what type of provider should be out there. So we can cover, this is Northeast Ohio, that we can cover the map of Northeast Ohio, but with the appropriate providers, appropriate locations. We can collate certain providers in certain locations for efficiency and cost, but still have that reach and footprint out as wide as we need to do. And what has this resulted in? It's resulted in a growth in our business. So we see a growth in spine surgeries year over year. We see a growth in injections year over year. We see a growth in E&M visits year over year. And we have grown. We currently, as of 2025, have 207 FTEs just within our spine department to manage this book of business. And of course, what the health system cares about is this slide only, which is revenue. So we've been able to grow our revenue, gross revenue year over year as well. But that's not just the business side. What else can we do? Well, we can work together to solve problems. So in around 2012, we identified a pretty significant issue with surgical site infections. But coming together as a big group, we decided on how are we going to care for these perioperative patients to prevent infections. We can agree upon an antibiotic dosing regimen. We can agree upon screening for MRSA. We can have one unified prep that we all follow, so we can just eliminate that as a cause. We can have routine and unified post-operative care. And we dropped our surgical site infection below 1%, and we kept it that way since that point. And that's not only good for patient care, but it also saved the institution significant dollars, and that's, again, they care a lot about that. We're also probably a more effective research team as one department because we're not just focused on spine surgery research, we're focusing on everything. We have, in our research meetings, we have our medical spine docs, our interventionists, we have pain psychologists there and ourselves, all focusing on the problems that we see within our population. We can understand our population of patients better. We can see how we treat certain diseases within our population of patients. We can do comparative effectiveness research very well if we want to make decisions on what type of treatments we should offer. And we can also innovate in research, which is one interesting from an academic standpoint, but then can help us in that management of those patients. And this is some work from Gaith Haboob, who is in our group, one of our faculty, who looked at healthcare resource utilization, a rush metric and calculation, which looks at how often a patient interacts with the healthcare system. This is actually a very good correlation with patient-reported outcome measures. So this is a good corollary to that. And why is it beneficial? Because you're recording this continuously. So we know that when we record PROMs, it's very sporadic and it's at different time points. And if you look at patients in between time points of PROMs, their trajectory goes up, it goes down. It's very dynamic. It's not very static at times. And you have no idea what's happening with that patient until you see them again. If you use the rush metric or this resource use calculation, you have continuous input into this, and you can see what's happening to those patients between those time points. So you know if they're getting better or getting worse. You fill in the data, and perhaps you can catch somebody very early and interact with them before you see them on that next visit. And it's also very good engagement for the entire team. So we have a spine outcomes research group, probably like many people in the room do. We have 2 medical schools, one on our campus and one slightly distant. So we continuously have about 40 medical students with us engaged and output, but it's also good for the team because it's the entire team that's there. So it's a team effort, it broadens our footprint, it broadens operations, and of course, we can have a good impact on research publication as well with this larger team approach. Education also benefits from this. So we have one unified surgical fellowship. And what I mean by that, it's not like we have orthopedic fellows that rotate with the neurosurgeons and vice versa, and it's kind of a combined fellowship. We truly have one fellowship where we have one fellowship director. We take both neuro and ortho fellows, and everybody rotates with everybody interchangeably. We typically try to match 3 and 3, 3 neuro and 3 ortho. We also have one single spine resident rotation. So on our spine service, we have neurosurgery residents and we have orthopedic residents all working somewhat interchangeably. So while I'm operating that day, I could be operating with an ortho PGY3, I could be with a chief resident from neurosurgery, I could be with a fellow, I could be with a combination of all of them universally. And we also have unified call. What we like to say is pedigree agnostic call. So when I'm on call, I could be on with an orthopedic resident who's not even on the spine service or neurosurgery. And you could say, well, how does that benefit you? Well, it's an educational opportunity that I have with my residents and someone I would never maybe interact with, right? That resident's not on spine, perhaps, they just happen to be on call. So it's somewhat enjoyable from that end. And we can partner with the system, right? We can work on saving money, and a goal, since we're a large group with a lot of leverage, we can have some of that money reinvested back into us. And we can do that with vendor contracts on spine implants, on spinal cord stimulators, et cetera. And we've been doing that for quite some time, and we've shown that we can do it, and we can save millions of dollars of doing it as a big group, and we can show that it doesn't hurt our revisions, our complications, our readmissions, and it really has no negative impact on our patient-reported outcomes. And then lastly, we're adaptable, right? So we heard through today, and we heard from Juan about AI. We need to be very nimble, and we can do that as one large group because we can interact with all the facets of spine care, right? So we can, if a new location opens up or a new opportunity, we can go grab that quickly. We talked about vendor contracts. Juan talked about AI and how that's going to impact us. As one larger group, it's easier to incorporate those technologies with us. Payer policy changes, we're all facing that. We can interact both on the medical end, the surgical end, and then we probably have greater leverage on payer contracts as well as this big group. Now again, there's been a lot of lessons learned. This is a very simplified presentation of this complex process over about 11 minutes. But things that we found which are critical for this is it's got to function like a true department, right? Not where you have neuro chairs and ortho chairs and you have a combined team leading your spine group. That really doesn't work. You have to have one leader running the spine group, and they can't be beholden to the chairs of the other departments. You've got to have your own strategy. That leader needs to be dynamic, needs to be egalitarian, right? We look at our group as partners. We're not neurosurgeons or orthopedic surgeons. We're providers, and we want to be treated as such. You have to have a single budget within that department. Obviously, control of the resources you need to make that happen. We co-localize. What I mean by that is our offices are all together. So next to me is an orthopedic spine pedigree surgeon. Next to me is a medical spine physician as well. So that sort of builds that sense of team. And then lastly, there are many, many centers out there that are combined programs, right? So meaning, you know, there'd be a building, a spine building, and you have people from the ortho department, neuro department, maybe pain management, all seeing patients in the same place, all collaborating with each other, and it works out very well. And that is a team. I'm not saying it's not. But that team is sort of like this pickup basketball team on the weekend, right? Everybody is playing together, and it's all going well until there's a hard foul, right? If there's a hard foul, someone can get their ball, pick up their ball, and they can go home, right? That's not an effective team. But if you have a department like we have, right, it's everybody rowing in the same direction. We've got all the linemen are necessary for the quarterback, for the running back, for the wide receivers. So everybody's working together, and when you do that, you can win a national championship. And that's, I think, what we have as well. So every aspect of what you need in a department is within our spine IPU, research, education, innovation, and we think pretty effective at this time point. So I thank you. That's just a quick snapshot of our 1 million square foot brand new neuro and spine hospital that's going to open up in 2027. I want to think that the success of our spine centers made a lot of that possible. Thank you very much.